Well, good afternoon and welcome to, this is actually, and I don't correct Dr. Bernard very often, but this is actually the 5th annual, Andrew, you said it was the 4th annual Richard Schwartz Symposium, but it's the 5th. And this is in honor of a great surgeon and a very great man, Richard Wayne Schwartz. And I'm going to say just a few words about Richard in a few minutes, but this is the 5th time we've had this special day celebrating the life and the legacy of Richard Schwartz, and his wife Janet is here today, as always. And we've had in previous years, we've had some remarkable speakers, starting with Dr. Ken Sharp, Dr. John Weigel, Dr. Gary Dunnington, and then last year, Dr. David Richardson. And now we're very honored to have Dr. Mike Edwards here, and he's going to be introduced in greater detail by Andrew a little bit later. But let me just say a few words about Richard Schwartz. He spent his entire academic career here. He was from Lexington. I know he wasn't born here, but he basically was brought up here. He went to Tates Creek High School, played football there, right, Janet? He's a great athlete, a great tennis player. And he went away to DePauw for college, and then he came back. Well, I'm sorry, then he went to UVA for medical school, and then he came back to Lexington when Ward Griffin, and I hope all of the residents at least know who the legendary Ward Griffin is, came back here for his general surgery residency when Ward Griffin was chairman here, before he went to the American Board of Surgery. And then did a fellowship in transplant surgery, did research there. He'd done quite a bit of research as a resident as well. He hated transplant and vowed, and when he came back here, Ward Griffin was very disappointed that he wasn't going to be a transplant surgeon, but that's the way it worked out. Richard was a very busy general surgeon. He did a full range of general surgery. When I came here in 1990, I took over his breast practice, which he was happy to get to unload, and then his endocrine practice, but he continued to be a very busy abdominal surgeon, hernia surgeon. He probably did more gallbladders at this hospital than anyone will ever do. He wrote many papers on a wide variety of research and clinical topics. He was best known as a surgical educator. He won just countless teaching awards for teaching over the years, both local here, statewide, and also national. He was the Association for Surgical Education National Educator of the Ward, which Educator of the Year Award, which is a really big deal. He was a president of the Association for Surgical Education, so he was a master educator, wrote a lot of papers about surgical education, was very interested before it was fashionable in physician leadership, and wrote a lot of papers about that. So he was just a great surgeon, but a truly great and unique educator. He would sit in his office, and there'd often be medical students sitting on his desk, under his desk, and behind his desk. I mean, literally, he'd have the whole group of students in his office. And he was absolutely passionate about education. So he mentored many students, many residents over the years, hundreds, and many faculty. He mentored me and many of the faculty that we have here today. So he was just truly a remarkable man. He was a absolutely devoted husband and father to Andrew and Sarah, grandfather. He was a man of faith. He was very active in his local church. And he was truly unique, and he was just a huge loss to the institution and to Lexington, to the state of Kentucky. So this day is to honor him, to honor a great man and his legacy. So we're glad you're all here, and we're very privileged that Dr. Mike Edwards is here as well. So we are going to start the day. And by the way, many of the former residents, faculty, and friends of Richard, surgical colleagues in Lexington have supported this day. And there is information about how you can be financially involved if you so wish. I sound like a sort of a KET public television person, but really, it's been very well supported. But please feel free and don't be shy about contributing. At any rate, Richard was like me and believed in patient-based education, talking about patients if you're wanting to learn medicine or surgery. And he really disliked lectures, and it's sort of ironic that there's a lecture in his name. I think he would be quite amused because he believed in the Socratic method of teaching and just talking about cases, and he would do that in his office, and he would pepper the medical students and residents if they were there on rounds or whatever with a lot of questions. And one of my favorite quotes is Sir William Osler, who is Montreal's most famous physician, also Johns Hopkins. He ended up at Johns Hopkins after many years in Canada. But he said that to study medicine without books is like sailing without any charts. And to study medicine without patients is not to go to sea at all. So if you don't talk to patients, interact with them, learn from them, examine them carefully, learn their stories, it's going to be very difficult to be a good physician or a good surgeon, and that applies across the board. And Richard was a big believer in looking at patients, their stories, and learning from them. So that's all by way of to say that we, 6 of the PGY 3s, one exception, Sam Walling is a PGY 2 and was conscripted for a very obvious reason. But we have 6 presentations. There are 6 stories about patients, and we don't have Richard to pepper you all with questions, but we do have Dr. Edwards. So you don't have to be shy, Richard, and any of the other faculty that want to contribute. And so I'm going to call now on Dr. Heather Sinner, and she's going to talk about a disease that you're very familiar with, Mike.
Hi there. So Heather Sinner, presenting on an axillary mass. So a 55-year-old female, she presented...
She also happens to be a 55-year-old woman.
Yes, so she's a human. Yeah.
Residents describe them as males and females.
I apologize.
It sends a larger sense of empathy when we describe them as women and men. So she's a 55-year-old woman.
She is a 55-year-old woman. She presented to her local hospital with a painful mass, or multiple painful masses, in her left armpit, her left axilla, that she felt were increasing in size. A little bit about her: she has some acid reflux, generalized anxiety, which she didn't take any medications for, seasonal allergies, and of note, she is postmenopausal. She's previously had a tubal ligation, was a prior smoker, doesn't use any alcohol or drugs, and has a family history notable for a brother with lung cancer.
You know, when you hear that, one of the first things that comes to mind is she's in the age bracket for a woman who becomes more susceptible to breast cancer, and that can be the source of masses in the axilla, but not usually painful. And
right.
So when you see painful, you start to think more about other inflammatory diseases of an infectious etiology or of some kind of weird disease like tuberculosis, some kind of injury, some kind of other weird fungal infection, something like that. So all those things become a little more prominent in your diagnosis, but go ahead.
So her physician did a focused physical exam on her and found relatively normal vital signs. She's mildly obese, BMI of 25, or mildly overweight, I apologize, BMI of 25. No skin lesions that are notable, clear lung sounds, a normal cardiac exam. On her breast exam, her right breast, bilateral breasts are generalized dense tissue, but there are no discrete masses in either breast. In the left axilla, 2 lymph nodes were palpable, and again were tender to palpation.
Okay.
So she underwent mammography. Here is a sample of her photos, the left and the right breast, respectively. Both breasts demonstrate dense tissue and a stable nodular fibroglandular pattern from her previous mammograms. Again, no masses were noted, and there were no suspicious signs that she had something going on in the breast. Because of the left axilla palpable nodules, she underwent an axillary ultrasound. This is the one representative photo I have of the left axilla, which shows one of the two nodules. This one is the 2 by 1.5 centimeter nodule. The radiologist reported it as likely a lymph node, however, no fatty hyla noted. And again, at that time, they didn't say it was concerning for carcinoma or anything abnormal, just that it was enlarged. They did decide to biopsy it because of the tenderness and the size, and the biopsy came back as relatively interesting. Poorly differentiated carcinoma with possible squamous differentiation. Some of the tumor markers that were positive were CK7, CD56, P40, ER, and GATA3. And of note, negative would be mammoglobin, PAX8, PR, TTF1, a variety. Through these tumor markers, the pathologist said that it would favor a breast carcinoma, however, cannot exclude lung malignancy, given the positive CD56 and P40 being the squamous differentiation, and then GATA3 and ER being positive, concerning for breast.
Had she had a chest X-ray recently?
So at this point, she hadn't yet. She does. Okay. My next question was, what would you do next?
No, you're not going to ask me questions. I'm going to ask you questions.
Okay.
That's the rule. Go ahead.
Well, so her primary doctor suggested a chest X-ray, and she had one, and it was normal.
Okay.
We then thought we need to discuss her when she was referred to our facility at our multidisciplinary breast tumor board, given the concerns for a breast primary, and then do further imaging, considering staging CT chest, abdomen, pelvis, and then specifically an MRI to see if we're missing a occult breast lesion.
The situation is that it is an unknown primary that presents as a regional metastasis. And the idea of most of those in the axilla are obviously going to be breast. Most of them you'll actually see on a mammogram, but occasionally you won't, and then you won't see it, and then you're going to wind up. You'll pick up most of them by the MRI. The MRI is much more sensitive, but it also will generate a fair number of false positives as well. So, but in this case with the squamous cell, yeah, it could easily be in the lungs as well. So tell us what you found.
So her chest, abdomen, pelvis was actually, there were no abnormal findings. She had a bone scan as well, no bone metastases. Oh, I thought that this, ignore, I'm just going to show you the images and tell you what I saw.
Okay.
The MRI. So here's on the MRI, if you look at the left breast, you can actually see a lesion on the left breast. It's irregular mass. It's at 1 o'clock, measuring 17 millimeters in size. And then if
you didn't see that on the screening ultrasound either, because it's
No.
tough to do a screening ultrasound on the breast because there's so much tissue to cover, and it only sees a 1 millimeter plane. So we don't really think about ultrasound, but I would still many times look, and certainly if you saw any kind of symptoms or had any symptoms, look with ultrasound. But you didn't see that. You didn't see it on mammogram, and now you see it on MRI. Okay.
the MRI further back in the axilla really highlights the axillary lesion. This is one that was measuring 3 centimeters in size. The second lesion on MRI measured 2 centimeters in size. So with this information and now seeing that a previously occult breast lesion, we decided to do a second look breast ultrasound to confirm the breast.
That's where your yield is actually going to go up, because you're going to use the MRI now to focus where you do the ultrasound. And I would point out that in terms of your surgical group here, really great to see David and the work that's being done with him in ultrasound. The ultrasound should be to the surgeon today what the stethoscope was to, when I was your age. Really, surgeons should, I use the ultrasound to see the cephalic vein for cut downs. I use it for breast lesions, neck lesions, for placement of lines. Really the only way to go, and it's really changed the way surgeons practice, particularly with vascular access, et cetera. So
Absolutely.
you're going to do nail biopsy trying to establish the primary?
We did that, and we were able to establish the primary.
We did that. Did the radiologist do
Yes.
that, or did the surgeon do that?
That was the radiologist that did that, specifically the breast-specific radiologist.
Okay.
Found that left breast lesion, did 7 passes with a core needle biopsy, as well placed a clip at that time. Pathology came back as poorly differentiated invasive ductal carcinoma. with lymphovascular invasion. Tumor markers, ER was negative, PR was negative, and HER2 was negative also.
And did you compare the path? Is there a possibility you're dealing with two primaries here?
So, right, a little confusing because on the previous biopsy, the ER was positive, but the PR was negative. That was some concern and discussed in tumor board, but thought to be unlikely the case.
And tumors do, and metastasis can be a little bit of a differentiated nature. I'm not sure about this. This is pretty unusual. David, do you have any thoughts about that?
It's obviously, quite unusual.
Yeah. All right, go ahead.
So given her hormone receptor status and the local extent of her disease into her axilla, she underwent port placement and had chemotherapy neoadjuvantly. She
Put your port in.
she has a right subclavian, so without an ultrasound.
Without an ultrasound? You did a percutaneous stick?
Sure did.
What's your incidence of pneumothorax?
My personal incidence, 0.
Well, my point is that, you know, I use a cut-down technique. It is a little more expensive, it takes a little bit longer, but it also lets me teach residents how to cut down on a cephalic vein. And I'll also have to say that there is literature suggesting you can minimize the risk of pneumothoraces using an ultrasound technique, particularly with an IJ approach, and tunnel the catheter over the clavicle. Now, I certainly have partners that have stuck with the classic subcutaneous subclavian stick, and it certainly meets the standard of care. But you have to wonder if we shouldn't be a little more diligent in adopting image-guided approaches.
Absolutely.
All right, go ahead.
Underwent dose-dense neoadjuvant chemo with adriamycin and Cytaxan, followed by Taxol for 12 weeks.
Let me ask you, when you did the ultrasound-guided biopsy, did you leave a marker at the site of the tumor in case she had
Yes.
a complete response?
Yes, she had a U-clip placed.
Great, thank you. That's important because sometimes these patients will have a complete response, and then you don't even see the scar. It's really difficult to figure out where you want to go. So that's
Absolutely.
standard. Yep.
She actually had a great response. She no longer was able to palpate her axillary nodules. Again, we were never able to palpate the primary breast, but on repeat imaging prior to surgery, everything started to look smaller. So she was able to undergo a needle-localized lumpectomy and an axillary dissection. And here I have a representative picture of our,
There's your clip.
here's our surgical specimen with the wire in the clip. And our surgical pathology, our lumpectomy specimen showed no residual carcinoma.
For her.
And the axillary, again, 11 lymph nodes were removed and 0 had any kind of cancer in them. In fact, 2 of them showed therapeutic changes, fibrosis within the
What was the title
nodes.
of your axillary operation?
Title.
What do you call it?
Uh,
Is it a level 1-2 dissection, a radical axillary dissection?
No, actually, this is more of a limited axillary dissection. So a level 1 and 2, but then specifically even narrowed, we did sentinel lymph node mapping in order to find if there were any specific lymph nodes that had high uptake that we should focus in on.
Interesting.
So we didn't do the full axillary, take all 30 plus nodes that you find, leave her with lymphedema.
What's the next step in her therapy?
So her future plans, given that she had a complete pathologic response, she's going to undergo whole breast radiation, but there is no further systemic chemotherapy needed at this time.
Okay.
And so I brought up a few teaching points, which you have.
Well, before
Okay.
you get to that,
Yeah.
let me ask you, what are you trying to accomplish here?
Cure,
Cure. What is your definition of cure?
resolution of cancer.
No, that's not the definition of cure.
I'm not sure then.
You're not sure, but yet you went into surgery. Surgery is the most powerful tool that we have to treat cancer, and you can't define cure. Well, don't feel alone, because I went to ASCO one year, and we were talking about cure, and I was asking people what they thought cure was. And some of the best answers I got were when survival curves so to cure, you really should understand the definitions of what it is you're trying to achieve. And in fact, you know, when we do coronary atherosclerotic heart disease operations, we don't cure anybody. We palliate their symptoms and we extend their life by increasing survival time among patients who are not cured of coronary atherosclerotic heart disease. When we treat breast cancer today, thank God, with the drugs that we have and the operations that we have, we actually can cure patients. And when we say cure, what we're talking about is to cause this woman to live a life expectancy equivalent to age-matched cohorts who never had the disease. So that's what a cure is. And it's really important to understand that. And many of you don't. And in fact, nearly all of you don't. And you revert instead back to studies where we look at survival curves. And when we see survival curves separate, we know that we've added life. So when two survival curves separate, what is that? Why do they separate? There's a difference in area under the curve. What is the area under the curve? You've got number of patients over here, and you've got time here. What's the cross product of the area under the curve? That's right, patient years. And so if the curves separate, we know that we gain life measured in the cross product of something we call patient years. There are two basic scientific methods by which those curves separate. One, we increase the number of patients who are cured. We change the percentage of patients who are a cured fraction. But there's another way those curves separate. You don't have to cure anybody. How would they separate if you didn't cure anybody? You would cause all patients to live a bit longer. So you can increase time without curing anybody, increasing median survival time among uncured patients. Or you can cure a fraction of patients, or you could do both and the survival curves will separate. Now, why does this matter? The reason it matters, and you should be thinking about it, how old is this woman?
55.
55. So I went back in 1994, and I wrote Dr. Bonadonna, and we got the data from him about the original trial of adjuvant chemotherapy in the treatment of breast cancer. And we followed those women for 25 years, and what we saw was the number of women dying of breast cancer was the same whether you received CMF or not. Yet the survival curves separated as the first demonstration of the efficacy of chemotherapy in the adjuvant setting. So then we knew that the impact that Dr. Bonadonna had achieved with CMF was solely due to increasing survival time among uncured patients. So if they lived long enough, they were going to recur. And they were going to die. And that's why we started seeing recurrences at 10 and 20 years after chemotherapy had given them the opportunity for the survival curve to separate. Here's the good news for this lady. With the advent of modern chemotherapy, we no longer achieve separation of survival curves just due to increasing survival time among uncured patients. We are curing patients. And this lady now at 55 years old with potentially 30 or 40 years of life on the line could absolutely be cured. So you're right about that. It's not just increasing survival time. All right, go ahead.
To add a few teaching points as far as considerations for giving someone neoadjuvant chemotherapy, anyone who has stage 2 with a HER2 positive breast cancer, node positive or triple negative breast cancer, or inflammatory breast cancer should definitely be considered. And then also if you're looking to downsize the tumor in order to go from a mastectomy to breast conservation therapy, then you can consider neoadjuvant. Again, it's also sort of as you're alluding to, a great tool to see the tumor respond. Is it going to respond or not? And then another teaching point of the role of MRI in breast cancer, which you've brought up, definitely beneficial when you have an occult lesion and determining the extent of disease, especially in someone with dense tissue. So that is my presentation. I thank you for allowing me to present.
Thank you, Heather. Dr. Nick Jackson is next. He's going to switch gears a little bit, talk about an abdominal case.
There we go. Good afternoon. I'm Nick Jackson. I'm going to be talking about a strange case I got to be a part of. So our patient is a 78-year-old woman presented to our hospital with an acute onset of abdominal pain and bilious emesis. Further diving into her history revealed that she had been treated for cholecystitis 7 months prior at an outside facility with percutaneous cholecystostomy tube.
Why?
Presumably for all of her medical comorbidities. She was a pretty poor operative candidate, especially for an elective procedure. She had pretty bad heart disease, CHF, CAD, COPD. She had a stroke with residual right-sided deficits, morbidly obese.
All right.
Had never had a prior surgery. The tube had been removed some months prior to presenting to our hospital. It's unclear how long she had been without the tube.
Well, you know, when you treat infection, which acute cholecystitis is, we have the 4 Ds. I don't know if we have medical students here: drainage, debridement, diversion, and drugs. Drugs being the least effective in the treatment of an infection, but the most important thing is complete debridement of the source of infection. Mm-hmm. That's why we typically do cholecystectomies in good risk patients. A cholecystostomy creates the drainage, but it doesn't do the debridement.
Correct.
And so it's not a great procedure, but it might be the ideal procedure for the person that you described with the increased risk. Mm-hmm. You know, my impression is I see cases of cholecystostomies done when I think it should have been a cholecystectomy and vice versa. Mm-hmm. So you got to just make sure you apply that where it's needed. So tell me what happened.
Certainly. So she came in, she had a white count of 11.5, normal bilirubin, was a little alkalotic as would be expected from her continued emesis, but otherwise hemodynamically stable. Abdomen was tender, distended, but no peritonitis, nothing saying that she needed anything emergently. We had time to work her up. She underwent a plain film x-ray in the ED, which showed an abnormality in the right upper quadrant. That was starting to push us towards a suspected diagnosis. And I wanted to ask, in today's era of advanced CT scanning and all of the different modalities for imaging we have, how often would you consider any sort of surgical intervention based on solely a 1-view x-ray?
Yeah, I don't know what we're seeing here. And what's the interval between now and when she had her cholecystostomy?
7 months.
7 months.
Yeah.
Well, I mean, it depends on your confidence in your diagnosis. You see free air on an x-ray, you operate on the patient. You certainly don't get a CT scan. But go ahead and tell me what you got here.
Yeah, so we didn't see any free air, so we, with her being stable, we pursued further imaging, and she got a CT scan, a couple representative cuts here, demonstrating kind of air or pneumobilia, and then kind of an apparent connection to the duodenum, and then this large object in the third part of the duodenum.
You mean a gallstone ileus? But
I mean gallstone.
And it looks like she's got a stone in her right kidney. Is that right, or is that just contrast?
That was just contrast.
It is
If
just
you-
contrast. Why
yeah,
don't you
scrolling
see it
up
in her
now.
left kidney?
That I'm not sure. But
Yeah.
scrolling through the images, that washes out.
Okay. Yeah, I was thinking that was a
So,
stone
yeah,
as well.
correct. Gallstone ileus. A fairly rare diagnosis, about 1 to 4% of all small bowel obstructions. More common in older individuals and often has more, significant medical comorbidities to go along with that. Only occurs in less than 1% of patients with gallstone disease. It's an interesting diagnosis that's intrigued physicians for centuries. First reported in the 1600s.
Where's the obstruction usually occur in the small intestine?
Most commonly in the ileum,
in the ileum,
hence
right?
the name.
Yep.
So originally described in the 1650s on an autopsy report. The first large trial of 131 patients underwent 125 surgery in those, reported by Courvoisier in the 1800s, had a 44% mortality rate, compared to today's literature that shows about a 12 to 27% mortality rate. Our patient specifically had a subset of gallstone ileus known as Bouverie syndrome, originally described by Leon Bouverie in 1896. It's essentially a gallstone impacted within the duodenum, causing a gastric outlet obstruction. Exceedingly rare, only 1 to 3% of those with gallstone ileus. Have you ever encountered, maybe not Bouverie, but a gallstone ileus in general?
I have never treated one personally as a surgical oncologist. I've certainly seen them. The first one I saw presented in the classic form was at UT in Houston when we arrived there and Frank Moody discussed it. So tell me what you're going to do right now. Now, where's the stone, by the way, at this point?
D3, third part of the
D3.
duodenum.
Okay.
And with her being a pretty risky candidate, we weighed our different options, surgical versus endoscopic.
Right.
Obviously, surgery would be a midline laparotomy, mobilizing the duodenum if need be, opening it up, oversewing transversely. A big surgery on a pretty sick woman. So we consulted with our GI colleagues, and there's actually new literature out that's been in the past few decades about advanced endoscopic techniques. And so we elected to pursue
Yeah, I
with
think
that.
if you want to establish continuity in her small bowel, and so relieve the obstruction. It turns out that the biliary enteric fistula, we create those when we do biliary enteric bypasses. And so with the inflammation, assuming she's not on steroids like the case was presented earlier today, you can wind up leaving that intact, and particularly in terms of not getting into that in a 78-year-old woman. So tell me what you did and how you got the stone out.
So we consulted our GI colleagues, and they took her to endoscopy. And as you can see here in the first image is a large stone completely obstructing the duodenum.
It is, that's beautiful.
They ended up having to use a colonoscope to have bigger tools to break up the stone.
Right.
But they were able to extract a portion of it, and the rest was seen washing downstream after they broke it up.
Okay. And now, so she still got her cholecystostomy too?
No, the cholecystostomy tube had been removed.
It had been removed.
By her outside provider months.
Okay, and so
before
that had
presenting.
fibrosed in.
Correct.
So you're going to leave that alone and leave that as is, correct?
Correct.
Good.
So she did well. Post-op day 0, started tolerating clears, advanced to a regular diet the next day. Hemodynamically stable, looking great, discharged home in stable condition.
Great.
But this wouldn't be much of a surgical symposium if we didn't operate. So unfortunately for her, she returned
Oh, my goodness.
on post-op day 3.
No, it'd be a great symposium
Yeah.
if you could tell me this 78-year-old lady who's high risk avoided an operation,
Yeah.
that you thoughtfully treated her with a cholecystostomy, got the tube out, got it to fibrose. Her gallbladder is contracted now, it's gone. And now if you have to do is relieve the obstruction. And now you tell me she's obstructed again?
She's obstructed again, this
What
time with
from?
a true gallstone ileus. A portion of the stone apparently had broken off and then had not been collected and had worked its way down.
Okay.
So, our GI colleagues were confident that they were able to get the majority of the stones.
Well,
and
that's
the
the problem.
fragments.
You got a medical man doing a surgeon's work.
Yeah.
All right.
But
All right, go ahead.
this time we obviously knew she was going to need an operation.
Oh, my goodness.
When approaching a patient like this, would you go after the gallbladder at the same operation?
No.
Yeah. Okay.
No,
Yeah.
absolutely not. She's 78, she's fragile, you're going to leave that alone, you're going to go in and you're going to make an enterotomy proximal to the stone and pull it back up and be done with it and close it. So
And that's
tell me what you did.
That's exactly what we did. We made a small mini laparotomy,
Yep.
eviscerated her small bowel, ran it from ligament all the way down to IC valve, palpated the
beautiful.
stone.
Isn't that beautiful? Just look at
Yeah.
this. This is surgery in its finest hour. The only thing that could make this operation better, if you could find an abscess to drain. Isn't that beautiful? Look at that. That is, now,
was that.
I am a little upset at your GI colleague for leaving that thing in there. I don't
Yeah.
think a surgeon would have.
The measurements of it ended up
Are they
being
here?
3.5 centimeters.
Of course not.
So it measured in at 3.5 centimeters
Wow.
in Flowers dimension. Unfortunately, we didn't get a weight, but it was a pretty big one.
And was it impacted in the ileum?
It
where they
was, and there was
typically
actually
are?
another smaller piece too. This
Yeah.
was the largest piece. There was another smaller piece in there as well that we extracted.
Yeah.
We closed her enterotomy in transverse fashion.
Yeah.
Closed her back up. She had an umbilical hernia repair at the same time, so she got a 2-for-1.
Wow.
Did well on the floor.
You're not trying to make this lady completely well. You leave the fistula alone, you get that out, close it, nice little incision. Now tell me she did well, please.
She did well. She did well post-op. Had return of bowel function on day 3. NG tube was removed, advanced to regular diet, discharged on day 5. Came back and saw us 2 weeks later in clinic, had been eating and doing just fine, having bowel movements. And
Very
well.
well managed by the surgeons, I might add.
So what this case taught me is, despite her having failed endoscopic treatment, endoscopy has a lot of merits and can be done on a lot of sick people to prevent major operations. I don't think she would have tolerated a big foregut operation as well as she did the mini lap we were able to provide for her.
When you go back and you look at the original cholecystostomy placement, did they not pick up on the fact that she had, or had she had any evidence of the fistula at that point in time?
It's unclear. I was at an outside hospital and we weren't able to get those records from
And it also
months.
comes back to my point about when you do cholecystostomy versus cholecystectomy. If you're going to do a cholecystostomy, it's got a stone in there that large, you ought to maybe figure out a way to take it out, because that's not just a placing a cholecystostomy tube.
And you would
I
presume
wonder
after
what
removing
the
tube.
timing was on the formation of such a large stone like that. And, you know, I don't know that it's related to your cholecystostomy, presumably not. Any thoughts about that, Andrew?
Yeah, this is my case. I didn't do her second operation,
Okay.
but I cared for her in the beginning. Conversed with my GI colleague when he said, it's smashed up and it's out of the duodenum. And I'm the guy that gave her regular and said, ma'am, I think you're going to be fine. And I let her go with my phone number, and she turned back up. So it's my case. I agree with everything Dr. Edwards said. Don't attack these cholecystoduodenal fistulas for sure. I suspect, of course, this is how you get these, that gallbladder had been hot and smoldering for months, if not a year or more. The cholecystostomy got her through an acute episode, but it continued to smolder, I suspect, subsequent to that, with that large stone, and then eroded sometime after that
Interesting.
cholecystostomy tube was removed, I suspect. Had you done a cholecystogram, and there's a broad range in practice for this, of course. Some people will do a cholecystogram before they take it out. Some people don't. Had you done a cholecystogram, maybe you would have seen an early cholecystoduodenal fistula forming. Not big enough for that thing to get out.
You mean prior to taking out the cholecystostomy
Right.
tube? I see, I see.
What we know is that a third of these patients that get cholecystostomy tubes at 6 months are going to not be alive. So they're going in, or they should be going in a population of patients who is very comorbid.
Right.
And you may not have to do anything in a fair number of these patients because they may succumb to the medical comorbidity that kept you from
From
operating
doing it in
on.
the first place, right?
We do see it a little overdone, though, I think, these days
Yeah.
sometimes. You're still going to
question.
have to occasionally do a hard gallbladder operation, and that goes to clinical judgment, your point number 2.
I mean, Mike, how many cholecystostomies did you do as a resident? Because they were open then. How many? Do you ever remember doing one?
Yeah, I did one. And I went to Monday morning walkarounds, and I won't ever do one again up there. But, yeah, I remember doing it that weekend, and Dr. Polk and Dr. Richardson really took me to school. I'd read a paper, but I let a young attendant convince me to do something that they didn't like me doing.
Pat, did you do any as a resident?
Yeah,
I
we
did
did.
one or two.
We did. The thing that I find interesting, we never took one out because those patients never survived.
Yeah.
You did it where there were times you did almost a cut down.
Yeah, yeah.
And the gallbladder
Right.
was open there. You
And
put
just,
the first
yeah,
string
and
popped
be
it
done
out.
with it, right.
And there was an old adage back in the day that you never did enough gallbladders until you did a cholecystostomy tube, a subtotal cholecystectomy, or you left the entire back wall of the gallbladder in the liver bed.
Yeah.
And because you hadn't done enough hard ones, if you hadn't done at least those
Well,
3 things.
You know, Pat, you bring up something really important because I was talking to Doug Tyler from Gallstone, and we were talking about how many subtotal cholecystectomies that we had done in our careers, and I don't know, 1 or 2. And we were talking about the fact that the young people today do so much laparoscopic surgery, they don't do very many opens. And operations that you and I would have done a cholecystectomy on today are being done with a subtotal cholecystectomy, leaving the infundibulum, and then using cautery or argon beam or whatever to ablate the mucosa and putting in a drain and oversewing from the inside the cystic duct. There's nothing wrong with that. You got to be comfortable that you're not going to injure the common bile duct. But we are seeing a lot more of these subtotal cholecystectomies. I think we've got some guys in practice in the back, and certainly during our eras, didn't see that nearly as often as you would today, would you? All right.
Thank you.
Thank you.
Okay, the next speaker is Dr. Sam Walling, who's PGY2, so go easy on him. Sam's going to skip yours again. We're going to go to the neck. You know, when Dr. Mayo said of abdominal surgery and neck surgery, the abdominal surgery is recreation compared to the hard work of the neck.
Oh, my goodness.
I like that quote.
Well, I'm going to attack endocrine surgeons later, so.
Fair enough.
So this is a case of recurrent thyroid cancer in an elderly gentleman that we saw in our endocrine surgery clinic here over the past summer. So he's a 68-year-old gentleman who presented to us with concern for recurrence of his papillary thyroid cancer. His past medical history relatively benign, other than his history of thyroid cancer. He was on an appropriate dose of Synthroid when he presented to us, and he had no previous head or neck surgery other than his total thyroidectomy 3 years ago with his initial presentation of cancer. He also had no family history of any endocrine malignancies. So
What is PTC? I hate acronyms.
papillary thyroid cancer.
Oh, okay.
Yes, sir.
All right, thank you.
So his story actually began back in May of 2015 at his primary care physician at his annual physical, when his primary care physician found an asymptomatic thyroid nodule on physical exam. He was worked up with an ultrasound and eventually with an FNA that was consistent with papillary thyroid cancer.
Okay.
Yeah, the next month he went to an otolaryngologist at an outside hospital that performed a total thyroidectomy with a central lymph node dissection. That pathology came back with a 1.9 centimeter tumor in the right thyroid lobe with positive margins. And they also had 2 of 2 central lymph nodes that were positive for metastatic papillary thyroid cancer. The following month, after tolerating the operation well, he did undergo radioactive iodine ablation, and then in August of 2015 had a total body radioiodine uptake study that showed no evidence of any uptake.
Okay, good.
So now we fast forward 3 years, and he had been followed by this ENT with serial thyroglobulin measurements for surveillance, and he, in June of this year, had an elevated thyroglobulin for the first time to 91.4. He then had a ultrasound of his neck that was concerning for a remnant right thyroid with a nodule measuring 0.8 by 0.9 centimeters within it. So at that point, he was referred here to our endocrine surgery clinic. And upon meeting him in the office, he was completely asymptomatic. He had a very benign physical exam. There were no palpable nodes. There were no palpable nodules within his neck. And so as...
Sorry, Sam, just for the medical students, what should his thyroglobulin have been after total thyroidectomy and after radioactive iodine ablation?
it should be near zero and then nothing.
Basically zero.
Yes, sir.
Yeah, so he's got active thyroid tissue somewhere, and you've already ablated him, so he's got a recurrence of disease.
Yes, sir.
Radioiodine scan was negative, so this is dedifferentiated papillary.
Yeah.
Non-radioiodine.
And, you know, if you're going to make a diagnosis on this guy and you're going to intervene, you know, getting access to it, seeing it, and doing an image-guided sampling of the area to confirm it would be, at least in my mind, the way to go. After an operation like this, you know, Dr. Polk has always had a saying that reoperative surgery is not pretty, and as David alludes to in the neck, you got vital structures in close proximity now with scar, so the likelihood of injuring a nerve, you know, having a problem with parathyroid glands goes up. So this is one where I'm not qualified to really comment on the approaches at this point in time in terms of how you're going to take this or deal with this, but I definitely want to get a diagnosis of tissue if I could, although it may be a diagnosis with thyroglobulin only, and you could go to treatment. Is that wouldn't be the case? You'd still get a tissue, right?
Well, history, physical, ultrasound.
Yeah, that's what I meant.
That's the,
Right.
the ultrasound is our stethoscope.
Right.
And you actually couldn't walk into our clinic without getting an ultrasound.
Well, that's what I meant, but you'd try to see if you could see this with an ultrasound and put a needle into it.
Right. So, speaking of that, so in the clinic, as we usually do with an adjunct to our physical exam, we put him in the ultrasound room. This is, I'm going to show 3 different images here of his ultrasound. This is his remnant thyroid tissue that you can see measures there about 2.2 centimeters, and in the middle he has that nodule there. It's solid. It's hypoechoic, and it does not have any calcifications. But usually in PTC, it's very common to see those calcifications. And so,
That's not too. Yeah, that's not too. That's obviously something suspicious in this setting. It doesn't look terribly ugly. It's a small remnant, which should have been ablated by the radioactive iodine. So that's suspicious. So that's what had been found on the outside ultrasound. But
correct.
then,
Yeah. So this was the only finding on the outside ultrasound. But when we looked in the lateral necks with our own ultrasound, we did find a number of abnormal lymph nodes. This is one on the right side, a level 3 lymph node.
And why do you think you found that and the radiologist at the other place didn't? Well, the reason is,
No.
that's exact. Who said that?
Dr. Bouverie.
Yeah, Dr. Lee. Well, because you, as a surgeon, and this is a really important point, are committed to an integrated radiographic or image, clinical, pathological correlation, integration. And so you're going to put it all together so that it fits. And if you've got an elevated thyroglobulin like that and you don't see something typical on ultrasound, you're going to look in places the radiologist isn't going to look because you got skin in the game. And so I really like that. So that's why you find this, because you're the person as a surgeon that should be integrating all aspects of therapy. All right?
So just as an introduction to the medical students and a review for the house staff, when we look at these lymph nodes in the office on ultrasound, there are a number of different characteristics that we can use as a constellation to determine if they're likely malignant or benign. This is a large node. It measures in its greatest dimension just over 1 centimeter. Its shape is round, where most lymph nodes that we see that are normal are more elliptical. We look at the circumscription of it. Parts of it seem to be well circumscribed, but kind of on the left and right sides of the screen, there's some areas that are that are more poorly circumscribed, which could be indicative of extranodal spread of disease. We also look at the echogenicity. This is hypoechoic compared to the surroundings. And we look for that nice echogenic linear stripe corresponding to the fatty hilum, and it's usually lost in malignant nodes, and in this particular node we cannot see that stripe. We also look for calcification. There's a couple of peripheral calcifications here that is standard of, a common finding in papillary thyroid cancer. And then I don't have any Doppler images, but we can throw the Doppler onto it and see that the vascularity is either central or peripheral, peripheral being more common in malignant nodes. In this node, Dr. Sloan commented on having chaotic vascularity, which is certainly a finding in malignant nodes. And we also found another one here with similar findings. It's somewhat poorly circumscribed. It's a very large node at 2 centimeters. It certainly does not have that nice echogenic stripe. So with all of these abnormal findings in the neck, in addition to the ones that we already had seen on the previous ultrasound, he had a right remnant thyroid bed with a nodule that was greater than 1 centimeter. He had multiple suspicious central nodes as well as bilateral lateral neck disease. And so from that point...
So you don't really need to put a needle in that if you're going to do a dissection, right?
Well, we did put a needle in
Did
it,
you?
just to confirm. Yes, sir. So this, in the FNA, everything that we stuck a needle in came back as cancer, of course. This here's a typical FNA slide from papillary thyroid cancer. They have very prominent nuclei with prominent nucleoli, and the nuclear contents are usually have.
And you should look at these with your pathologist. You got a cluster of cells that don't respect each other, if you will. They cluster too tightly together, sort of classic findings. So good.
So Sam, tell Dr. Edwards how it's done in our endocrine surgery clinic with the pathologist.
Sure. So we, Dr. Sloan and his partners perform the ultrasound there. Once we identify that we want to perform an FNA, we call the pathologist. They come over to that room.
Nice.
We have the microscopes and whatnot in the room, and so we have an immediate diagnosis.
Great. And you make the slides for them?
I do not. I never
Do
have.
you make the slides or they make the slides?
Well, I
Maybe.
have done that, but not here.
Okay.
In the old days. But so the students and the residents get an opportunity to look
Yeah.
under the microscope. And then we also can do, if we need to do, if it's an atypical biopsy, we can do molecular testing, take a sample for molecular testing.
Make sure you say thank you to those pathologists.
We do.
That's
We
really
do,
nice of
yeah.
them. All right, go ahead. But it's good for the patient to get that one-stop shopping and that efficiency. All right, go ahead.
So one of the things that I think this case really underlies for me is how important it is to do your own ultrasound, to not trust the
Got it.
imaging
Yeah,
that
yeah,
came
sure.
from the outside. Dr. Lee, when she was a
Before you
fellow...
leave the case, what's the plan now, or what have you done?
Oh, I'll get there.
Okay.
I'll get there. Yes, sir. So Dr. Lee, when she was a fellow down in Texas, published this paper on surgeon-performed ultrasound. It was a retrospective review of 109 patients. looking at specifically surgeon performed ultrasound of the lateral neck. And they found that they had a sensitivity of 88% and a negative predictive value of 97% of identifying nodal disease from thyroid cancers. And of 109, of those 109 patients, only 4 had missed disease after the final pathologic diagnosis. And then similar, this is a paper from this year actually. It was a retrospective review of 92 patients. And they compared outside radiology to surgeon-performed ultrasound. And in patients that had normal outside studies, 45% of those actually had abnormal surgeon-performed ultrasounds.
Yeah.
And so it was obviously a more sensitive tool for us as surgeons to truly evaluate our patients and get them the correct therapeutic intervention.
But that's my point about the integrating the pathology, the images and the physical exam. All right, so what'd you do next?
So we took him to the operating room. We performed a completion thyroidectomy, a radical central and upper mediastinal lymph node dissection, and then bilateral.
And this is the kind of case, at least in my, if I have to guess, is one where you'd really worry about injuring nerves. It's reoperative surgery is not pretty. You're there. You're going to use belts and suspenders, any tool you can to keep you from cutting a nerve.
Yes, sir.
All right, so tell me what happened.
So we did, then we did bilateral modified radical neck dissections. On the right side, those level 3 nodes that we just saw in ultrasound were very adhered to the internal jugular veins. So we did
Adhered? That's not a word.
They were adherent to.
They were adherent, right.
Yes, sir. They were adherent to the internal jugular vein. And so we resected the vein on the right side and left all 3 of the structures on the left side. And so just as a review for the house staff, radical neck dissection, we take lymph node levels 1 through 5. And then in the true radical neck dissection, you also take the sternocleidomastoid, the internal jugular vein, and the spinal accessory nerve. But in the last 20 or 30 years, it's become more common to do a modified radical neck dissection, in which at least one
Where
of those
was that
3
operation
structures-
largely originated? What institution?
I don't know. I know it was the first to describe it was Dr. Kreil. I know that, but I do not know where he practiced.
It was actually popularized and used in sort of high volume at MD Anderson by Bob Byers and Oscar Gillamandegi. But go ahead.
So this is this is not our patient, but just kind of what it looks like afterwards.
That's my patient.
It is your patient, yes, but not this specific patient, I should say. Yes, sir. This was our operative specimen. So here, closest to me, we have the right lateral neck dissection, and then the left over there, and our central nodes and the remnant there at the bottom.
Sam,
yes, sir.
go back to, where's the cancer?
So.
Classic papillary.
Right. I don't know how I can. I'll just. So you kind of see some
Purple.
Yeah, the purple here.
Yeah.
The purple tumor.
Beautiful.
So our final pathology, the nodule in the thyroid was recurrent papillary cancer, and then these are our lymph nodes here, and we had metastatic disease to all 3 of the lymph node basins there with numerous nodes bilaterally. And so for this case, I think the biggest learning points for me were the importance of surveilling our patients. I know in the endocrine surgery clinic, we see patients frequently that just come in for ultrasounds to make sure that we identify these diseases early.
All right, I think we got these 3 points covered, but tell me, what are you going to do next for the patient? Anything?
Yes, sir. So he underwent radioactive iodine ablation.
He did, yeah, good.
He did, and we then found that his
Were there any other residual uptake sites after?
He had no uptake, and so we don't believe that he that we can detect his cancer with the iodine study. So he then got a PET scan,
Okay.
And he did have one small area in his neck that did have uptake. He's currently seeing the thyroid oncologist here for further evaluation and management of that.
Is there any role for external beam in these guys, David?
That is hugely controversial. We discuss these. We have a twice a month tumor board where we present thyroid cancer cases. We are in general very skeptical about the role of external beam. Some of our people here are more stronger proponents of it. It is extraordinarily controversial. In any situation. For somebody like this, I don't think it's
Okay.
appropriate. It is a tool, but it has a lot of morbidity. Actually, there was a paper from here, we weren't involved, but showing the morbidity of external beam radiation in this particular group of patients.
All right, Well discussed, well presented.
I'm sorry. Oh.
Go ahead.
So then, I think it really just underlines the importance of surgeon-performed ultrasound. And
Yeah, we got that.
Yeah, Dr. Sloan sent me a nice photo. I don't know if you recognize that young surgeon
that
teaching
person?
some UK
Oh, my goodness.
Not
residents.
very much gray hair.
Is that me?
That's you.
Oh, my
I
God.
took that 25 years ago when you were at UK teaching breast ultrasound and biopsy
Oh,
to the residents.
I remember that. I remember that symposium. I came over here to do it.
Yeah.
Yeah.
And so do you want to comment on, I mean, you've done a lot of work and taught breast ultrasound. Do you want to talk about it? Do you want to comment at all?
Yeah, I'll make a couple of comments. First of all, some principles in ultrasound. I think that you have to remember that when you're ultrasounding, you only see basically a millimeter diameter plane. And so when I, for example, go in the operating room, I try to also make sure that, and these are just basic principle things for medical students to learn, but if the patient's head is up here, then I'm going to sit down, not stand up, because I don't want to look down at my probe and then look up at the monitor. So I make sure I sit down and minimize that angle so that I go down and I see the monitor here, looking here, and then I orient it, particularly if I'm looking at a vein or doing a biopsy. Particularly if you're doing a biopsy, you want to get down your head, get that in the same line, and then when you ski the probe across the lesion to make it move right to left, and then once you get it in the center of the probe, then you paint like a paintbrush, if you think about painting with a paintbrush, till you optimize the diameter. And then you have the hypothenar eminence of your hand sitting on the patient, your fingertips on the probe, you're holding it. You've got a nice ergonomic picture for you. And then I'll do lots of these without gloves, actually. You shouldn't quote me on that. But so you numb up the skin, take an 11 blade, do a little nick, and then you can take a spring-loaded biopsy, slip it through, and then I just slide it down underneath the probe, and then when I see the tip of it, guide it right up in front of the lesion, fire it, and pull the core out. And it really is something that surgeons do so much easier and so much more facile than radiologists. So from a technical point of view, that's just a little bit of how you do the image-guided biopsy in breast. But I could not imagine examining a breast patient without an ultrasound, because each time you feel an area of fibrocystic mastopathy, you can put the probe on it, verify, okay, that's nothing, move on to something else. You don't have to worry about it.
Dr. Lee introduced ultrasound to our practice, and
Yeah.
what I learned pretty quickly about ultrasound, and I think it probably applies to ultrasound across the board, that it is very easy to become mediocre.
Yeah.
It's really hard to become.
But even if you're mediocre, it can dramatically change the efficiency with which you engage patients and make diagnoses. So for example, when you're trying to learn to use ultrasound of the breast in particular, you start with a BI-RADS 5 small breast cancer, and you want to get a diagnosis on this larger breast cancer to receive neoadjuvant chemotherapy. So it's easy to see the lesion. Do the biopsy, confirm that it's a cancer. And then as you get more comfortable doing that, then later on you'll be able to actually do biopsies in the breast and then leave a lesion there when it comes back benign. But that's a much more differentiated expertise in terms of skill than just biopsying an obvious breast cancer. Yeah.
Thank you.
Yes, sir. Thanks.
I can't resist making one comment about, because you alluded to this, about neck dissection. So George Cryle and then, of course, Memorial really pioneered radical neck dissection.
Right.
Okay.
Yeah.
So I've done probably hundreds of neck dissections for cancer of various kinds, including thyroid cancer. But I don't think for thyroid cancer I've ever done a radical neck, a true
Right.
radical neck.
A modified
And
radical
we
neck. Right.
basically virtually never take level 1. I've only once ever seen, and there's somebody with recurrent thyroid cancer, level 1 involved. That's the subinhibitor submental nodes.
Right.
2, 3, 4, and I usually take a good number of level 5 nodes, so 2, 3, 4, 5, as well as the central nodes if you're doing a central node dissection. But I have what I do want to say is you mentioned Oscar Gilman-Dagey and Bob Byers, who trained me when.
And they were trained by Dick Jesse.
And they were trained by Dick Jesse, who really was the legend at MD Anderson. And
He was the
started
original head and neck
as
surgeon,
as
right?
I just told you. He was the grandfather of our famous Dr. Cortely.
Yeah.
So that's the coolest source. Yay. Yay for Dr. Jesse.
Right.
And so anyway, the next case, we're going back into the abdomen. It's kind of a messy case, and Dr. Kyle Best is going to present that.
Good afternoon. I'll be presenting a case of a 67-year-old gentleman that presented to us with an acute abdomen.
Okay.
67-year-old gentleman had a past medical history of urothelial cell carcinomas and invasive high-grade cancer. He had been treated with this transurethral bladder resection by our urology colleagues here. He also had a history of a past stroke with some residual hemiparesis and DVT in the past.
What was the etiology of his stroke?
Ischemic stroke.
Okay.
Our urology colleagues had planned to proceed with a radical cystectomy and ileal conduit. However, prior to that...
So he's got an advanced bladder cancer at
Yes,
this
sir,
point.
he
Yes,
does.
sir.
Prior to them being able to perform that surgery, he was hospitalized in early August of this year with pneumonia, acute cholecystitis, and choledocholithiasis. Unclear exactly why, but he was discharged home with a planned outpatient ERCP.
Did he have a cholecystectomy?
He did not,
Okay, so he resolved that with antibiotics, presumably?
presumably, yes, sir.
Okay.
Excuse me, that ERCP that was planned was performed here. These are some kind of details from that procedure. They had difficulty cannulating the common bile duct. It seemed they were preferentially cannulating the pancreatic duct. So they actually stented the pancreatic duct to facilitate common bile duct cannulation.
Now,
They did
now back up a minute. I guess I'm missing something. Show me the slide before. The one before. Okay, next slide. So he's got choledocholithiasis and acute cholecystitis. You're going to treat his choledocholithiasis first with ERCP. Okay, all right, go ahead.
Yes, sir. We had not been involved ourselves up to this point.
Good. And here's the problem. You're wandering far afield. You know, I went to Emory Medical School. We had a rotation at Grady Hospital where we had a saying, don't do something, I forget what it was, with the pancreas. And don't ever slap a man chewing tobacco. And so I think when you start putting these stents in here, in the pancreatic duct in this guy, you know, I think more along the lines of maybe he needs a cholecystectomy, maybe he needs a laparoscopic bile duct exploration for his choledocholithiasis, and then if that fails, then you go to ERCP rescue and you leave his pancreatic duct alone. If you can leave the pancreatic duct alone, leave the pancreatic duct alone. Maybe you ought to abort this before you start playing around with a guy's pancreatic duct. You stay away from this pancreatic duct. There's a lot of bad things happen down there, but anyway, go ahead, you'll tell me it'll be fine.
Unfortunately, we'll talk about some of those bad things. So this gentleman went home. It was an outpatient ERCP. He went home, was home for about 48 hours, had worsening altered mental status and seizures. His wife took him to that same outside hospital emergency room. He presented an extremis there, was resuscitated briefly, and then transferred to our emergency room via
So our
helicopter.
GI guys did this ERCP, and they didn't call you about this at this point in time, right?
Well, they didn't know about this at this point. He had gone home.
I know, but your guys did the ERCP.
Correct, yes, sir.
But there's no surgeons involved.
No, sir, we didn't know about it
This is
until
a surgical disease, and out of I don't want to admonish them too much, but they need to call you, notify you it's a surgical disease on a patient who's a sick patient. At least you're in the loop.
Yes, sir.
And vice versa. I'm going to beat on my surgeons. If you're going to go in and do an approach and do a laparoscopic cholecystectomy and think about a laparoscopic common bile duct exploration, you should call your GI guys and say, hey, if I fail at this, I may be calling you for an urgent ERCP. But you guys aren't working together the way you should. And trust me, it happens in Cincinnati too.
Yes, sir.
But you could have worked together better with your medical colleagues on this.
Yes, sir.
All right, go ahead.
He arrived here, was essentially immediately intubated. We were called at that time because of his acute abdomen. You can see his heart rate, his vital signs there, his lab values.
Right.
And then his physical exam. He was obtunded, respiratory distress, and had peritonitis.
Well, doctor talk would indicate that this gentleman is tachycardic, hypotensive, tachypnic, hypoxic, and has prerenal azotemia and pancreatitis.
Yes, sir.
That's what we call doctor talk.
Yes, sir.
And we would encourage that as opposed to what residents these days do, and God knows it's true in Cincinnati. You give me a bunch of numbers and stuff, and you don't really give me differentiated assessments in terms of the lingo of a fully trained doc.
Yes, sir.
So pay attention to how you speak about symptoms on the subjective side as much as you do some of this data, and also pay attention to the words you use and how you differentiate your understanding of what's going on. Because I don't see a lot of assessment up here. I see a lot of numbers, and I don't like numbers.
Yes,
All
sir.
right, go ahead.
A CT scan was...
Oh, by the way, back up one. I left out dehydration. It looks like his hemoglobin's 14, but go ahead now.
We're able to obtain a CT scan. I have a short video of this here.
Yeah, go slow.
Yes, sir. It's
Looks
playing
ugly.
See if I can try to scroll through it a
I
little
hope I
bit
didn't see free air around his pancreas.
Maybe go through it again.
Yes, sir.
Yeah,
I'm
go
gonna try
through
to-
and show
I'm
me
going to try
what
to
I'm
do it
seeing.
manually here, see if I can do that. Here we go.
Is that a stent?
It is.
Okay.
Yes, sir.
There's a pancreas.
I think this
The
is the
vein.
best representative cut here. You can see this extending into the retroperitoneum through the uncinate process.
Okay. Okay. God bless him.
Just a quick slide reviewing the pancreatic anatomy. You can see obviously the pancreatic duct here, concerned that the stent had essentially perforated through this area into
Yep.
the retroperitoneum. There is a classification system that I read a little bit about. The Stafford classification system, you can see the 4 types of endoscopic perforations that are described, type 1 being a frank perforation of the duodenum.
You know what this system tells you? That the IQ of the individual that made it up is not very large. And so it's insulting to these medical students to have to say that Dr. Stafford, whoever has a type 1 and a type 2, if he were really an intelligent person that cared about communicating something, and it may be an attending here, I hope it's not, you would label that as a type 2 and what it does. You just say it has this criteria. The other one is this one, the other one's that one. I'm never going to remember what type 1, 2, 3, 4, except I'm going to know 4 is probably worse. So you're not doing anybody any favors when you create some kind of numbering system on classifications. Make it descriptive and use words.
Yes, sir.
You won't forget that. All right, go ahead. So what happened?
Just a quick point on ERCP, just because we deal with them or order them or ask for them frequently, the perforation rate after ERCP is 0.39%. The type 3s and 4s here account for 75% of those. 37% require surgery at some point afterwards, and the mortality is 8%, so a significant mortality rate after an ERCP perforation.
Yeah, you can round that 3.9 off. You can say about 5%.
Yes, sir.
All right, go ahead.
Can I just ask a quick question?
Yes,
So
sir.
I want, like Dr. Evers to comment. So we had at one point in time, one of the general surgeons was an expert ERCP.
Yeah.
Okay, and you, of course, worked in Louisville.
With
for
Gary
a long
Vitale.
time With Gary Vitale. So
Right.
do you want to comment about, no, I don't know what your situation is in Cincinnati, but do you want to comment?
Well, we have
about-
GI guys do it in
about
Cincinnati.
surgeons.
They have a
doing
very
ERCP.
tight relationship with our surgeons, and I think it works really well, and we do not have a surgeon that does ERCP. I will tell you that it is much more ideal to have a surgeon do ERCP. They tend to think that way. I do think that over the years, Gary candidly has become a little more callous and a little too willing to pull the trigger and use ERCP, and is certainly pretty liberal about its use, like a lot of the GI guys. But yeah, I think the problem with it is that the learning curve to do ERCP is very, very substantial. it takes a substantial commitment, and unless it's going to be a major part of your practice, which is going to be by far the majority of surgeons. The problem with Gary's program is that he's trained a large number of surgeons that, you know, spend an inordinate time doing ERCP and then don't adopt it when they go into their own practice. And so I wouldn't necessarily encourage a young person to do it unless they were going to a pancreatic center and already had the job that they knew that was going to provide them with the cases if you were going to do it. All right, go ahead.
Sir.
That's a problem.
We were consulted, of course, and he presented to us in extremis hypotensive, tachycardic, and respiratory failure. We emergently took him to the operating room, performed a laparotomy, and cochlearized the duodenum. On entry to the abdomen, we found a large volume of turbid fluid. The pancreas was saponified. We could not visualize a gross duodenal injury. Our GI colleagues did remove that pancreatic stent. They left the common bile duct stent in place as it was a metal stent.
Yeah.
We placed Blake drains posterior and lateral to the pancreatic head and in the lesser sac, and placed a temporary abdominal closure device. 24 hours later, approximately, we returned to the operating room, this time performed a Cattell-Brash maneuver.
Yeah.
Still did not visualize a duodenal injury, and at this point, confirmed our drain placement as well as placed an nasojejunal feeding tube. Just a brief illustration of the Coker maneuver for the students in the room. Essentially, take down the lateral attachments of the second and third portions of the duodenum and reflect immediately to see posteriorly. And then the Cattell-Brash maneuver. Mobilize the right colon, the hepatic flexure, reflect immediately, take down the small bowel attachments on the right
You
lateral.
can actually sit the small bowel up on the
reflected out of the abdomen.
on the chest.
Yes, sir. Gives
When
you
you get that done.
more exposure to the third and fourth portions of the duodenum to
Yeah.
adequately examine that. His postoperative course is very complicated, as Dr.
Sure.
Sloan indicated, but he did have a high output pancreatic fistula with over 1 liter per day. He had a subsequent second stroke. He went into renal failure. He had a significant pneumonia, bacteremia fungemia. Had a clinical decline on hospital day 17. We returned to the operating room at that point. The family wished to give him one last look in the operating room. He had some patchy areas of ischemia in his small bowel. Returned to the ICU, and the family at that time were elected to withdraw life-sustaining care.
Well, it's unfortunate. I mean, this is a iatrogenic death.
It is.
Now, you could argue, oh, there's some chance he'd die, and it is true of a properly done operation without intervening with the scope, but it's quite unfortunate.
Yes, sir. Obviously, a lot of teaching points here. I was going to briefly discuss pancreatic fistulas. You can kind of categorize them into internal and external fistulas. Obviously, an internal fistula communicates with the peritoneal cavity, the pleural cavity, or a hollow viscous organ. An external fistula communicates with the skin. And then, obviously, you can categorize them based on their cause, either iatrogenic or not iatrogenic. This was, of course,
It's
an
quite
iatrogenic.
descriptive, and it's not type 1 and 2 is what I was alluding to. Yeah.
Yes, sir.
All right, go ahead.
The management of pancreatic fistula is two-phase, essentially the resuscitative phase, which is when on presentation. It's mostly supportive care, correct electrolyte abnormalities, keep the patient NPO, and then distal feeding is imperative as well.
Getting back to the resuscitative phase, before you took this guy to surgery, I presume you tried to correct his lactate, you tried to make him hemodynamically more stable.
Yes, sir.
Made a good gallant effort at that, got him as good as you could get him before you went back.
We did. Yes, sir.
How long did you spend doing that?
An hour or two, not terribly long. I think we were concerned at that time. We weren't sure. We didn't know exactly what was causing this, and there may have been a duodenal perf, or there may have been an infectious
It doesn't matter.
source.
I mean, all the more reason to try to make sure that he's going to be stable enough to get anesthesia induced, and you're not dealing with a crisis from the immediate time you get there.
Yes,
is
sir.
all I'm asking. All right.
Octreotide can be used in the resuscitative phase. It's a somatostatin analog. This does decrease the amount of the output, but does not increase closure rate. And then the kind of subsequent phase of treatment can include endoscopy, ERCP specifically, with stenting across the injured duct if possible, as well as a sphincterotomy to allow adequate internal drainage. That correlates to about 85% closure rates. Percutaneous drainage also is an option, and that can externalize an internal fistula in about 5 to 10% of cases. And then finally, surgical intervention months down the road. If the fistula itself the tract is fibrosed,
Yeah.
you can perform a fistulojejanostomy.
We've done a number of those in Cincinnati. We have a very large pancreatitis practice, and Cy Ahmad's done a number of those.
If your ductal injury is more distal, you can perform a partial pancreatectomy, distal pancreatectomy, or pancreaticojejanostomy if indicated.
All right, we'll discuss.
Andrew, do you want to comment?
Tough case. Bernie Boulanger used to call this disease retroperitonitis.
Yeah.
It's usually what you would call a step for 2 here, I guess, a periampullary.
That's what the endoscopist thought.
Yeah, that's usually the case. I've never seen this problem before. An unusual problem, but obviously a disaster. Because now it's in the mid-body.
Yes.
Yeah.
But the people, physicians that end up talking to the family, repeatedly, and going through all this agony with the family are the surgeons, and never the physicians, right? That are,
Well,
that have caused the problem. I mean,
well,
but it goes with the territory, I guess.
I'll talk about that in my talk this afternoon, but I think that we have the advantage of decades of accountability of hurting patients with a knife and then justifying it by beneficial intervention. Some of the medical subspecialties are not steeped in decades of morbidity and mortality conference and go into procedurally related specialties for the purpose of having a better income and of using their hands, and they're not steeped in the accountability that we are afforded as a luxury, which holds us as a discipline accountable to our patients and our interventions. And that's why we do the discussions with the patients in a more reliable and fashion than they do. It's not just that we are better people. It's the fact that we have a more richer history of surgical accountability that goes back decades and decades.
That's fair enough. Thanks, Tom. Is Dr. Wright here? Tiffany, I'm going to invite you to come up to the front. Dr. Tiffany, and Tiffany is going to be introduced by Dr. Bernard later, but Tiffany is one of our fabulous former residents who is now a pediatric surgeon and works at that institution an hour down the road, I-64, that you're familiar with.
Oh, okay.
She's a pediatric surgeon.
Okay.
So the next two cases, and the reason I've asked Dr. Wright to come up at the front is because the next two cases are kids.
Go great.
So I figured, Mike, you can maybe use some help. So,
I think I could definitely use some help.
so the next speaker is Dr. Rob Keynes. So, Rob, come on up and
My friend Mary.
Good afternoon. I'm going to be presenting a case on a 10-year-old boy who presented to the emergency department with some abdominal pain. RW, 10-year-old boy, otherwise healthy, no past medical, no past surgical history. He came in with 2 days of acute right upper quadrant abdominal pain radiating to his right shoulder. His mother was a paramedic, was not concerned at first until he started having fevers of about 103 at home, had some nausea and vomiting, presented to emergency department. His vitals are below. Here he was afebrile, tachycardic, normotensive, not hypoxic. Went down and was fortunate to evaluate him. He appeared pretty uncomfortable, not in any acute distress. He was overweight, was breathing normally, no adventitious lung sounds, He was tachycardic, but he had regular rate and rhythm. On abdominal exam, he was soft, non-distended. He did have some right upper quadrant tenderness. No peritonitis, however. No palpable hepatomegaly or splenomegaly on exam. Here are some of his labs that we got while in the emergency department. As you can see, he had a leukocytosis. Other than that, pretty uneventful labs. We did get a right upper quadrant abdominal ultrasound. As you can see, kind of here, he has a heterogeneous mass. When measured, it was about 8.5 by 5 centimeters. Looking at this, discussing with radiology, could be abscess given the internal debris.
Is that his liver?
This is his liver, yes.
Okay.
Versus possibly a cavernous hemangioma. We did elect to get other imaging at that time. We got a CT liver protocol. We did see this mass here in segment 7 on multiple cuts is about 7.5 by 5 centimeters. It was multilobulated, as you can see here. It has some septations. Appears to have some internal debris. There's no rim enhancement here. Here's another representative slide. You can really see the lobulation, septations. After discussing with radiology, they favored infectious etiology, possibly a gonococcal or pyogenic liver abscess. However, this would be very unlikely in an otherwise healthy 10-year-old kid in the state of Kentucky. We also
Did he have any other lesions on his abdominal CT scan? Presumably you scanned the rest of his abdomen. You didn't see history of a perforated appendix or anything else?
No, sir. And on physical exam, did not have any physical exam findings consistent with appendicitis. We did get a chest x-ray because sometimes right lower lobe pneumonias can cause some referred pain and some pain to these areas. We didn't see any of that as well, but I didn't include that. So we did elect to get further imaging. Showed more or less of the same. No real difference. We then performed a diagnostic laparoscopy 2 days later.
Well, wait a minute. Wait a minute. Before you jump into that.
Yeah.
I mean, what's your differential diagnosis here? Because I don't have a clue what's going on. I'm concerned, in a 10-year-old kid, what's common that would seed the liver with a pyogenic abscess, which is going to be the most common thing? He's got appendicitis, something else going on. Is he perforated his gut somewhere else? Got a retroperitoneal abscess? You can't identify that, so you're showing me an isolated liver lesion, right?
Yes, sir.
So then I guess you do get back to some of these more strange and bizarre and unusual things.
Kind of going back to some of these things.
Can you let me finish?
Sure.
So my point is if you're going to put your diagnostic scope in, you need to think about what you're going to be doing based on what you find. And you have to have a comprehensive plan for each of the diagnoses that you could potentially be dealing with. You just don't want to be meddling around in there, spilling this stuff and causing bigger problems. And I'm not aware, I don't know how to treat this, and thank God I've got a pediatric surgeon here to tell me what to do.
Yeah.
Please.
So, this child was transferred.
He was what?
Transferred here with a diagnosis of liver abscess. You took one look at his images and said, there's no reason a 9-year-old should have a liver abscess. This is a malignancy until we know it's not. And so then you have to go down the differential diagnosis of a malignancy in a 9-year-old in the liver. Hepatoblastoma being the most common, which is why AFP was checked and was more.
But in a 9-year-old, and what do they present with fever?
Not necessarily. So he presented, you can see in some of those images that he had a ruptured lesion, which is why he presented with pain. He ruptured under his diaphragm and his precious capsule. As we go through his differential, we now need to think about what is it, how do we get a diagnosis? It's posterior liver, it's right on the diaphragm. The IR is going to go through it and get it. They have to go through his thorax and see his chest. So we elected to go
Okay.
different route and maintain this in the abdominal cavity.
Okay. Yeah, I wouldn't have necessarily understood or known enough. I'll have to show my ignorance to say that this is much more likely to be tumor than infection. I would have gone with infection, but I don't know these kids. So, all right, go ahead.
All right. Thanks, Dr. Ruzick. Yeah, we did perform a diagnostic laparoscopy with a high index of suspicion that this was going to be a malignancy until proven otherwise. We did note that he had a roughly segment 7-8 fungating mass that did, frankly, rupture. He was involved in karate and baseball and thought maybe that had something to do with some of his pain, but turned out not. It did rupture into the diaphragm and the peritoneum. We didn't see any frank pus, so that made us a lot more suspicious that this was something more malignant. We did leave a drain. We did take multiple biopsies of the rim, the core, and liver edges to try to get a very accurate diagnosis. On pathology, there was no evidence of malignancy in the fluid cytology that we sent. But this was kind of a representative histologic slide with some spindle cells, large pleomorphic nuclei, rare atypical mitotic figures, and then these eosinophilic granules. It was stained with everything and really nonspecific. No stains really came back positive. So after discussing with the pathologist, this was pretty consistent with an undifferentiated embryonal sarcoma. Just some teaching points, because this is a very rare liver tumor to diagnose even in a pediatric patient. Most commonly occurs in children less than 15, usually between 6 and 10 years of age. It's difficult to diagnose, so don't feel bad because it appears cystic and often delays management. People think it's often infectious. Prognostically, it's historically very poor. Usually 37 to 30% of patients didn't live past 1 year. However, today with advanced chemotherapy and radiation and improved surgical outcomes, it can be considered curable with an R0 resection. If unable to do that, you have a very high risk of recurrence within the first 1 to 2 years, and the treatment is described below. We did get, after this, we did get staging CT scans. Didn't see much in terms of metastatic disease elsewhere in the body, in the chest, or the rest of the abdomen. He underwent left subclavian port placement, consulted hematology oncology, and he was enrolled in the ARST 1321 clinical trial. In this arm of the study, he was given isophosphamide, mesina, doxorubicin, desrazoxane. He did not receive total abdominal radiation. The plans were for him to undergo 25 total weeks of chemotherapy, surgery following week 13. He did suffer some complications as a result of his chemotherapy. He had some neutropenic fevers and seizures associated with isophosphamide. After 13 weeks of chemotherapy, he did get restaging CT scans, and these are some representative cuts here that shows a dramatic decrease in the size of the tumor, as you can see here. We did take him later on the 1st of August for partial right hepatectomy, a non-anatomic resection of segment 7. We did elect to biopsy the diaphragm at that time, since there was evidence of tumor rupture at the diagnostic laparoscopy.
How do you judge the extent of your liver resection with the degree of tumor response that he had? And why didn't you do...
You almost always...
Let me finish again.
Oh, sure.
And why didn't you do more of a formal right lobe?
Mainly, we do intraoperative liver ultrasound. None of this mass was not involving any of the vessels, so we felt that it was appropriate to perform a non-anatomic resection in him with clear margins.
I don't know anything about the disease in terms of, if you have is it only viable disease that's going to recur if you get too close to the residual viable disease, or can you cut across areas of previous response? Mm-hmm. My thinking would be it'd be better to cut across normal liver But I don't know enough about the disease to comment.
Sort of treated like a sarcoma, so you just need to get clear margins.
Uh-huh.
They respond very poorly to radiation. There's a lot of discussion whether or not he needed abdominal radiation, which we were so reluctant to do for an 11-7.
Yeah.
But particularly since he ruptured on presentation. And that's the reason to get more cytology and more diagnostic.
Right, because of the rupture, right.
At the time of his resection, but really you just need clear margins. And there's only about 200 cases of this in the literature, so we're still, we can't say data says this, data says that. Other than,
Yeah.
we know that children who survived through resection and were resected with clean margins have long-term survival. And that's really poor data to give you, but that's all we really have. It's a rare tumor. Thankfully, a lot of kids in the 90s initially died because they were treated with chemotherapy, didn't really, and had complications of chemo and they never made it to resection.
Yeah.
But we use intraoperative ultrasound. Rob wasn't there for that resection support. This is a little bit unfair for him.
I talked to Dr. Berger about it right
Yeah,
before.
but we use intraoperative ultrasound to get really to healthy liver. You can see some treatment effect. This was encapsulated that helped us to actually get clean margins.
Well, but my point is I don't want to help to get clean margins. I want to get clean. Go back and show the liver, not that one, the original one. Yeah, maybe the right lobe's not what I want to do. I can't read MRIs anyway.
You went in there thinking we would do a trisympathetic,
Yeah. Okay, you did. Okay.
and it did not need to do that.
Okay. Good. Okay.
Based on really what we palpated and how that, we really went in resecting that initial tumor.
Okay.
Including that we resect whatever responded to therapy.
Right. All right.
All right.
Really strange case.
Yeah.
You didn't comment.
Because I didn't know what to say.
Well, I made a fool of myself. You left me out there on the limb alone.
So currently, he's doing pretty well. He's on 22 or 25 weeks of chemotherapy. He's actually able to hold and swing a baseball bat. I think he was actually admitted to the hospital not too long ago with another episode of neutropenic fever. So
Tough case. Okay.
he's a tough kid, too.
Bad problem. God bless him.
The biggest teaching point of this is that this EMT was referred to for radiologic access.
Yeah.
They came to the ER. I mean, this is always, telling a parent their child has cancer is difficult. Telling them that cancer when they came in thinking it's something else is really even more challenging. But that's not throwing the other institution under the bus. A lot of people have made this mistake.
I did.
That's the biggest, that's the biggest teaching point here.
Yeah.
They look like abscesses. They're very complex
Yeah.
lesions. They're cystic.
What percentage of them present with fever?
I don't know the answer to that, honestly.
Yeah, that's what's interesting to me. I mean, I even had leukocytosis, and that's presumably from the rupture.
I suspect this started growing ultimately violated the capsule.
Yeah.
Gave him a first type response.
Right.
Which is why leukocytosis and fever. But you can see why people thought it was infection.
Yeah.
So, but it was irregular. I don't know, there's some gut feeling inside of all of us that says that's not an abscess, not to mention that he shouldn't have an abscess. He's a healthy.
Yeah, we couldn't figure a reason. I was looking for somewhere else in his gut. Yeah. All right.
Thank you.
The last case, and we're doing really well for time, so we're just wondering if we'll have time for a good break. Dr. Wayne Chang's going to come and present another child, and I know, Jimmy, you've seen a few of these.
Another zebra.
Hopefully not too big of a zebra.
When I hear hoof boots in Kentucky, I want to see thoroughbred.
Exactly. All right, so my case presentation today will be on a 3-year-old who presented with abdominal pain. So see why. He was a 3-year-old boy, no past medical history, basically presented at home with acute onset of right abdominal pain, nausea, vomiting, went to his PCP. They were initially concerned with appendicitis. being the most common thing with right lower quadrant abdominal pain. So he was sent to the outside hospital emergency room, and he was actually found to be in hemorrhagic shock. He was tachycardic, his hemoglobin counts were low, so they bullsed him and they obtained the CT abdomen pelvis, which you can see some slices here. Most impressively, you notice there's a large right upper quadrant mass, ill-defined mass, and they unfortunately didn't use contrast, so it was difficult to get any additional information out of the scan. I do have a video of this CT that you can kind of see here and appreciate. So obviously this wasn't appendicitis, so he was transferred to UK Medical Center for further workup. So on arrival here, his blood counts had dropped additionally, and so he was given red blood cells and transferred to the, or I'm sorry, admitted to the ICU for resuscitation and stabilization. We were consulted in the emergency room, and were involved and were involved with this resuscitation. So I guess my question at this point would be, what sort of workup would be relevant in this child after he was stabilized in the ICU?
Well, it looks like he has a tumor that he probably bled into. It's a little hard to tell on that CT scan whether it's coming from the kidney or whether, but it looks like it's probably coming from the lower pole of the kidney, but it's hard to tell on that imaging. So
Right.
I would either want some sort of better imaging, like another an ultrasound or another CT scan with contrast.
Absolutely. So we did, in addition to additional imaging, which I'll show you in the next slide, our differential was fairly broad because we were unable to determine the origin of this mass. Like you said, it looked like it was coming from kidney, but we overread it with our radiologists here, and they couldn't really differentiate whether it was liver, somewhere in the retroperitoneum. So we also got hematology oncology involved at that point and sent off a couple tumor markers, specifically urine, metanephrines, LDH.
What did you send?
Urine, HVA and VMA, the metanephrines.
And so one of the most common dilemmas is when you have like a tumor somewhere in that vicinity, trying to figure out whether it's coming from the kidney or whether it's a neuroblastoma.
Correct.
And sometimes you don't 100% know until you get in there, but usually you can tell based on imaging.
Right.
So you sent the urine, HVA, and VMA to rule out neuroblastoma.
Correct. And then we also sent the LDH if this was like a lymphoma by some rare chance. And then because we weren't sure if this was coming from the liver, we also sent some AFPs and beta HCGs. So this was the a CT with contrast that we obtained to try to better characterize the mass. And this is just the coronal view. And then also have a transverse. And again, we looked at this with our radiologists, and it was very difficult to determine, again, where the origin of this mass was coming from.
It doesn't have like the typical claw sign of a Wilms tumor.
No. So we were kind of at a loss at this point because we wanted to try to come up with the best plan in terms of attaining a tissue diagnosis. And had this been a Wilms tumor, any sort of biopsy before a resection would have automatically upstaged them. So we had a very long and thoughtful discussion, kind of multidisciplinary between us and the hematology oncologist, and we ultimately decided on taking him to the OR for initially just to take a look, but a formal resection if we thought that was appropriate.
I think the biopsy's a resection, isn't it?
Yeah.
I've had one of these kids before that we didn't know for sure whether it was a neuroblastoma or a Wilms tumor, and you're right, biopsying a Wilms tumor is bad, but if you do a nephrectomy for a neuroblastoma, that's also bad because they get nephrotoxic chemotherapy.
Exactly.
And sometimes it can be hard to tell.
Wow.
Yeah.
Okay, I didn't realize that.
Yeah. So we took him for the OR immediately. Once we entered the abdomen, we got some bloody ascites. We did send this off for cytopathology at that time. And as we continued with our dissection, we noticed that there was a pretty intense desmoplastic response around the area of the tumor. We were ultimately able to mobilize the entire tumor from the adjacent structures. Most notably, it was pretty adhered to the colon, but we did not have to perform any sort of bowel resection, and were able to get the mass freed up. While we were in the ORs, the pathologist did call us back, and they noted small round blue cells. And unfortunately, this still carries a quite broad differential. I mean, ranging anywhere from like Ewing sarcoma to small cell lung cancer. So we still didn't have a definitive diagnosis. But since we were able to free up the mass, we decided at that point to just complete the resection, and we ended up doing a partial nephrectomy because we thought it appeared that the mass was originating from the renal hilum. And also in the same procedure, we placed a port in anticipation if this was a Wilms tumor that he would require adjuvant chemotherapy, and the hematologist oncologist performed a bone biopsy while he was in the OR just to check for any pathology there. So this is a picture of the specimen. It's pretty impressive. It measured the tumor itself measured 9 by 6 centimeters, but obviously it was a lot larger en bloc. And when the pathologists did their final staining, this was confirmed as a Wilms tumor. And this is at his actual pathology slide, and it's interesting because he has the triphasic histology, the features that are all favorable in this setting of Wilms tumor. So in terms of his post-operative course, he recovered pretty well from his operation. He did receive his first dose of chemotherapy while he was an inpatient, specifically with dactinomycin and vincristine, and then he was discharged home on post-op day 10. Since then, he's completed his therapy, all 9 rounds of chemo. He did receive some abdominal radiation for suspected rupture of the tumor preoperatively, and his treatment ended last month, actually. So just quickly about Wilms tumor, it's the most common renal malignancy, ironically also under 15 years old. I don't know where the cutoff came from. 10% of these cases are associated with a syndrome. So there's the WAGR syndrome, Dennis-Drash syndrome, and Beckwith-Wiedemann syndrome. They just all happen to involve Wilms tumor as a characteristic. And then about 5 to 7% of these patients will present with bilateral tumors. In terms of staging a Wilms tumor, there's 5 stages. The main ones, or the important groups being stage 1 and stage 2, where tumor has been completely excised without any spillage, and stage 3 and stage 4, where stage 3 is you've got rupture and spillage of the tumor outside of its capsule, and then stage 4, which is you have metastasis basically to the lungs or the liver. And then stage 5 is bilateral Wilms tumor. In terms of treatment, for stage 1 and 2, resection with adjuvant chemotherapy is the standard treatment for that. And then for stage 3 and 4, you still want to do a resection, but with the added triple agent chemotherapy in addition to abdominal radiation. And then for stage 5, because there's bilateral involvement of both kidneys, to avoid the morbidity of having to perform a bilateral nephrectomy, the decision is to pursue neoadjuvant chemotherapy to shrink the masses as much as possible, and then to proceed with a resection, a partial nephrectomy, and then proceed with adjuvant chemotherapy afterwards, depending on their histology. So the reasons why I was mentioning favorable versus unfavorable histology is because they do have dramatic differences in survival rates long term. So our patient did have favorable histology. He's at tumor stage 3, so his 4-year survival rate would be estimated around 94%. If he had unfavorable histology, that would be decreased to 72%. And most dramatically in stage 4 disease, the difference is over 50% in 4-year survival rate. So just the final teaching points for Wilms tumors. It's the most common renal malignancy of your childhood. Don't forget your staging scans. We did get chest, abdomen, pelvis scans with this child. The most important point is to avoid rupture when you're resecting the tumor due to the fear of upstaging the patient and then requiring abdominal radiation. And interestingly enough, in the 1960s, the 4 years or the survival rates were abysmal, like 20 to 30%. But with better chemotherapy and multimodal agents, that's now risen to over 90%.
I think one comment I'd like to make to the group is that we can learn a lot from the pediatrician and pediatric surgery community. They were challenged in the 60s and 70s, 80s with these very, very rare tumors, and they came together in a way that they created national protocols and sort of led the way in terms of multi-institutional studies and protocols that really took what was an incredibly difficult group of diseases to get their arms around, and then worked together very effectively to accrue the vast majority, the overwhelming majority of all these kids with these diagnoses into trials, and rapidly advanced our understanding of these rare diseases, while at the same time and during the same period, you know, the cottage trade of medicine and the lack of cooperation across institutions, we did not do the same with our more common adult diseases, and we literally lagged them by some 20, 25 years in terms of our cooperation. We're getting better today, but we're still not anywhere close to where we need to be. And so I rarely make a compliment to pediatric surgeons or that group, but I'll have to defer to that one. Word about the Wilms tumors?
No, that's a really interesting case, because when you got the biopsy and got the small round blue cell tumor, I mean, one of the things that would be really high on that differential is a neuroblastoma. Right. And typically with neuroblastoma, you know, the traditional teaching is if it invades anything else, you should just biopsy it and go, but, you know, do neoadjuvant chemotherapy. But because the tumor was ruptured and the kid was bleeding, like, I don't know that I would have been comfortable leaving it in there, so a partial nephrectomy seems to make sense. Yeah. You know, for a Wilms tumor, typically you take out the whole kidney, but we have kids that have bilateral Wilms tumors and they get partial nephrectomies, and you just surveil them.
Yeah.
Thank you. Thanks to all the presenters. Thank you, Dr. Edwards, Dr. Wright. And we are going to take a break now and reconvene what